The heart is driven by electricity that comes from a structure in the right atrium called the sinus node, which is why we call the normal heartbeat sinus rhythm. Electricity travels through the right and left atria, causing them to pump blood to the ventricles. Electricity gets to the ventricles through electrical conduction structures, the AV node and the right and left bundles. Blood is pumped by the left ventricle through the whole body. Atrial fibrillation occurs because the atria, normally driven by the sinus node at 60 to 100 beats per minute, are instead stimulated electrically from abnormal sources that activate at 300 to 500 beats per minute. Most commonly, one or more of the four pulmonary veins in the left atrium are the source of these aberrant impulses. The aberrant electricity travels from the veins to the atrial muscle, which instead of pumping starts quivering. Fibrillare, the Latin term for muscle fiber quivering, is the origin of the word fibrillation. The quivering atria stop pumping blood effectively into the ventricles, and their very fast electrical signals activate the AV node at extremely high rates. The AV node acts as a regulator that does not allow all electrical impulses through to the ventricles. However, the ventricular rate, from which our heart rate comes, is generally much faster than normal and always highly irregular in atrial fibrillation. Patients with atrial fibrillation feel poorly because the irregularity and fast rates cause palpitations, and the lack of atrial contraction diminishes the efficacy of ventricular contraction, which may cause fatigue, shortness of breath, and poor exercise tolerance. The objective of atrial fibrillation ablation is to eliminate those symptoms. Fibrillation also causes blood in the atria to become stagnant, which can lead to blood clots and strokes and often mandates anticoagulant medications. To treat atrial fibrillation, we attempt to limit the ability of the aberrant electrical impulses to conduct freely through the atrial muscle. We have a handful of antiarrhythmic drugs that we sometimes use for that purpose. In this discussion, however, we concentrate on ablation as a treatment for atrial fibrillation. Ablation works by cauterizing tissue in the left atrium surrounding the pulmonary veins so scar forms. The narrow areas of scar we form prevent the aberrant electricity from the pulmonary veins that causes atrial fibrillation from reaching the atria. As shown in this heart specimen picture, the four pulmonary veins appear to connect to each other, almost like a structure independent of the rest of the left atrium. Aberrant electrical impulses can arise from the area between the veins. Accordingly, we sometimes not only ablate around the pulmonary veins, but also make a box of ablations that join the circles formed around the veins at the back wall of the left atrium. We leave the front of the atrium untouched so as not to interfere with its ability to pump normally. While other factors are at play, this is the basis for ablation of atrial fibrillation. Because the left atrium is only 1 to 2 millimeters thick, structures outside the heart receive some of the energy we use to cauterize. Two notable structures are the esophagus and the phrenic nerve, which touch the heart. We protect the esophagus from damage by placing a balloon-like device in it. We constantly irrigate the inside of that balloon with cold water to keep the esophagus from overheating, which could otherwise cause a deadly hole or fistula between the left atrium and the esophagus. We protect the phrenic nerve, which makes our diaphragm contract, by localizing it with our catheters. We do so by pacing at voltages high enough to cause hiccups when we are touching the region where it is by the heart. We avoid ablating in those locations. Other nerves cannot be identified in this way and can be damaged by ablation. We sometimes see stomach bloating from damage to the gastric nerve from this. This almost always self-resolves. We do ablation under general anesthesia using the carto system that allows us to view very precisely the location of our catheters in the heart without the need for X-ray imaging. This system works much like a GPS that allows us to locate our catheters in a three-dimensional space and generate and navigate maps of the veins and the heart very precisely. In addition, we place an ultrasound catheter inside the heart to help visualize its structures. We start by making 3 needle punctures in the femoral vein in the groin. We advance catheters up that vein and into the heart. One of them is used to gain access to the left atrium, under carto and ultrasound guidance. We puncture the atrial septum, the wall that separates the right atrium from the left atrium, with a long needle placed through a dilator and sheath placed in the groin. We will now see an ablation recorded in real time, though played back at fast speed. After puncturing the femoral vein, we advance a soft catheter into the heart. We can visualize this catheter in carto even before it enters the body. We acquire the anatomy of the major veins, the right atrium, and vital structures within it, incorporating them into our electroanatomical map. We also acquire ultrasound images of the right and left atria and structures within the left atrium such as the pulmonary veins. We mark the superior vena cava to allow us to do the transeptal puncture. The transeptal needle, sheath, and dilator are pulled from the superior vena cava to the septum and used to puncture it, giving access to the left atrium. We then deliver ablation to the circumference around the right and left pulmonary veins, then make an ablation box in the posterior wall of the left atrium. Each 10-second ablation is represented by a dot. We see our catheter move to areas where we map for electrical signals or areas of nerve stimulation. When we complete the ablation, we check the integrity of our ablation lines by mapping, where red represents the desired result. When satisfied, we remove the catheters and terminate the procedure. Ablation is currently the preferred approach to treating atrial fibrillation. The overall success rate is around 85%, though some people need it done more than once. Our average procedure time is about 90 to 120 minutes. Most patients go home the same day and are fully recovered in 5 days. The most frequent complication is bleeding or swelling in the groin where we initially puncture. This almost always self-resolves. Other complications, including stroke and death, are not impossible, but they are extraordinarily unlikely. Ablations are performed by a highly skilled team of people, including nurses, techs, and doctors. All members are vital to the success of the procedure, and we are lucky to have a very experienced and excellent team at our institution. I hope you found this introduction to atrial fibrillation ablation and how we do it instructive. Thank you for watching.